Good afternoon or good morning. Let me check. Good afternoon, technically. My name is Christine Billings. I think I know 98% of this room. I coordinate the Emergency Preparedness and Response Program. Our offices are actually located in the Dakota building. For those of you who don't see my team around very much, that's because we're in a different building, and we coordinate emergency preparedness and response out of a building that's co-located with the Sheriff's Office of Emergency Management, which lends itself well to collaboration and being able to respond to either public health incidents or incidents with a public health impact. So my presentation, or this short little lunch and learn for you guys, is about medical countermeasures. So what we need to deploy in a public health event to mitigate the effects of whatever bioterrorism agent may have been released into the environment. And how one way that we're using to target vulnerable populations for our dispensing strategies. This strategy actually was picked up by the federal government in the last 3 weeks and is now about to become a federal best practice. So there should be some really cool stuff coming out about that once we get all the final paperwork in with the Assistant Secretary for Preparedness and Response at the federal level. So this is a hashtag. And when I did a presentation a couple weeks ago for the feds, which brought this to light, we talked about hashtags and how we can all use hashtags in social media to sort of search for common likes, common things, common information about whatever incident may be out there. So we've really pushed at our level to sort of hashtag all of those tools that we use for dispensing medications so that other agencies across the county, other agencies in our region, and soon across the nation can sort of find those best practices and those things that we're doing really, really well for emergency preparedness and public health. So I'm going to use the hashtag all through my presentation. These plans, once we get them finalized after the accreditation process, you will be able to find all of our stuff on the H drive, and we'll make sure that gets out in internal communications. So as an example, hashtag back to school, right? So anything we want to find on back to school, we'll be able to hashtag that. Another example, hashtag public health preparedness. So anything that we wanted to find on public health preparedness, we could hashtag it and go find it. So those are two examples. This is actually a training that we did last summer when we were doing a bunch of planning for Ebola related to personal protective equipment. So all events start locally. So when we go to respond, we see something going on, we're looking at surveillance data, everything starts locally. So we start with something bad, the event. And so we get notified, or we see it, we are the locals, and we respond to that event. Some of you are on the public health incident management team, and you may be assisting with that local response. Something is probably needed to make that response happen. And so when that happens, we look at the stuff that we already have on hand. Do I have enough masks to respond to a pandemic of influenza? Yes, no, probably no. So I am out of stuff locally. And the process that I use is I look across the region and I say, hey, partners, do you have masks? And they say no, because we're in the same pandemic. And then we send the request for those masks up to the state. The state looks across the state, every county, and says, hey, do you guys have masks? And they say, no, we're all the same pandemic. We don't have enough masks either. And then the state sends that request to the federal level. The feds say, hey, we have stuff, yay. They ship it back to the state. The state sends it to us, and then we get it out to these dispensing sites, or to the hospitals, or to long-term care facilities. So that is the process that takes place when we have an incident that requires us to get stuff out, or we have partners who don't have enough stuff, and we have to request it for them. So this would happen in an anthrax attack. So we have somebody who decides to release anthrax, we need antibiotics, we don't have enough, we send the request to the state to the feds back to the state to us. That site where we receive all of those things is the Jeffco Fairgrounds. And we exercised that site in June. So we received a bunch of pallets, we kind of rearranged the pallets, and then we sent them out. You may start to hear information about a full-scale exercise that we're doing. There are 2 of them that are coming, but the one next June will actually be all of our sites that are giving out things in an incident, receiving those things from us. So it will be 10 trucks driving across the county delivering pallets of empty boxes, but in a real event, whatever is needed. So how do we get things into the public? We use what are called points of dispensing. These are pods, and we have two ways to do that. We have an open site and we have a closed site. So the open sites are just what they say. They're open to the public, anyone can come to them. In reality, I don't care what county you live in because everyone in this region is all in the same boat. We've all been potentially exposed to, we'll just use anthrax. So our current plan, actually we're about to have 9 open pod sites. This says 8. We are working on a plan for 1 more open pod site because we identified that we have an area of the county that wasn't necessarily being addressed. So Amanda and another student had done some GIS work for us, and we identified that we had a gap in our planning. A closed pod site is some pre-planning and some agreements and lots of exercising and training that we do with agencies that have agreed to receive the medications and then do that dispensing themselves. So one of our big partners is Lockheed Martin, and they have agreed to receive all the medication for their 5,000 employees plus their 10,000 employees' family members and get that medication out for us. So rather than having 558,000 people, I now can take 15,000 off of that number. So this is a really big project that we work on, this closed pod site. One of them is the Denver Federal Center, so think about all the people that work there. If I can get them the medication and they can get it out, that takes all those people out of those public pods and it increases the speed that we can get the medication out. So our population, according to Dr. Data, is about 558,503. We have 48 hours from the time that we are notified of an incident, specifically anthrax, to start to get antibiotics into the population. So if we have 9 pod sites, I actually did the math for these. If we have 9 of those open dispensing sites, I have to be able to serve 1,200 people per hour at each pod site. At each site. That is a huge number. We have adopted the head of household model, meaning that if there are 5 in my household, I fill out the form for everybody in my house and only I have to stand in line. So rather than 5 people standing in line, now 1 person is standing in line. The average household size is approximately a little over 3. So we've just divided this number by 4, and we need to now serve, using head of household, about 323 people per hour. A little more manageable of a number. That is assuming everyone shows up with 1 form for their entire house. We have reduced our staffing numbers. Those of you on the public health IMT may have remembered seeing 72 up there for a while, that we needed 72 staff people. Through exercising, we've been able to reduce that number down to 25. So we need 25 staff members to pull off dispensing at each pod location per operational period, which is about a 12-hour time frame. So we're still going to need a decent number of volunteers and staff to pull off dispensing, but it's way better than having 72 staff per operational period. So if we employ this closed pod site concept, we have enough closed pod agreements to pull about 50% of the population out of our open pods. We've done a lot of work on closed pod dispensing. So we've now reduced the public pod burden, and this number, which was 1292, is now 646. So even if we do not use head of household, 646 is completely plausible. When we did H1N1 influenza vaccinations, Columbine High School, at one of their hours, did 700 plus people, which is super awesome. And that's using vaccinations, that's not just handing out pills. So using closed pods, we have reached a number that's completely able for us to do, assuming we get the staff to make this happen, of course. So let's get creative. So what we do a lot is challenge the process. So you'll hear EPR talk a lot about, well, we need to meet this capability, and we need to do this, and we have to document this, and all of these things that we need to do, versus doing what we know will work. And so we tend to challenge the process a little bit of, we're going to do it this way because we know it works, versus I'm going to do it this way because this is how you told me I needed to do it. So one of those things that we're going to do and that we have done is this best practice for dispensing medications to vulnerable populations. We do planning with, let's see, next page. We have created a closed pod model that is a just-in-time model. So when you think about long-term care facilities, the residents within that population are not able to get out. What? That's not cool. We're good. Okay. So the residents in those populations won't be able to get out to an open pod, right? So the best thing to do is create a closed pod with them. Jefferson County has 220 assisted and long-term care facilities. That's a lot of planning. And the staff members in those facilities change over an awful lot. So being able to do long-term planning, consistent planning with these agencies just is not possible. So even though my capability says that I need to do that, in reality, we're not going to be able to do that. So what we've done with the help of Pam Stevens, who's one of my planners, and Sarah Dunn, who is a practicum student working with us from the School of Public Health, we've created this just-in-time closed pod model. So we ran an exercise with this model. They were able to send us in, upon notification of an incident, send in an application that said, yes, we agree to do this, we will receive the medications, we will get it out to you. I sent back a handbook to them and let them be. And the next morning they dispensed medications to their assisted living side of their facility. So within 36 hours, knowing just a little bit about what medical countermeasures were, they were able to take this handbook and dispense medications. And so we've got some photos from this process. We recognize that even with our pre-established, as we're going to call them, closed pod partners, they don't look at this every day like I do. And so having this just-in-time handbook for even them will be a huge benefit to those agencies when it comes to dispensing. So the way pods work is you sort of do a staff briefing and then you hand out prophylaxis for the staff. So you want your staff to be able to come, you want them to be comfortable, you want them to come to work, you want to make sure that they know that their family members are protected. So if you remember a couple of years ago, we did an internal dispensing exercise for those of you who were here. We received the medications, we had some training, and then you were sort of deployed out into our dispensing sites to help work those sites. The same goes for those closed pod sites. They took the handbook, they did a briefing and a training for the staff that would be working it, and then they went about prophylaxing their own staff and then setting up the site. A lot of templates are included, supply lists. It's very clearly laid out as to what you need to do to set up a dispensing site. The nice thing about dispensing to these long-term care populations within there is that their own medical staff is there to answer the strange questions that are coming up. So rather than someone coming to a public pod and us not being able to answer the questions and having to send them to their primary care provider anyway, this allows them access to that resource right away. So that's a huge benefit for us. So the staff, they fill out their forms and they receive their medications. For Jeffco, we would receive medications for you as well as your family members. We have that on hand. And then the residents show up and they fill out the forms and they run through the dispensing site. We got lots of great feedback from doing the exercise. Font size was huge, huge. It needed to be huge. There were lots of questions about what is anthrax. So here these people are showing up, we're saying you need to show up because there's been an anthrax thing, not really thinking that these residents have no idea what anthrax is. And that's the problem with being so entrenched in something like we are, is we don't realize what the general public knows and doesn't know. So running this exercise was really, really helpful. Diana, who's the CEO of Eaton Senior Communities, she threw in that a couple of the ladies were pregnant, so these 70-year-old ladies were pregnant, so we were doing some sort of alternate dispensing, and they just thought that was the best thing ever. They thought that was so fun, just such a hoot. They were great sports, and they ran probably half of their assisted living facility volunteered to come through this for just a 2-hour exercise. Really great feedback. So we're tweaking the program, and the federal government picked up on it, and they're gonna take that handbook that we have and the process that we've created and sort of share that across the nation, which really at the end of the day, our goal is to get medication to people and protect the public, so I don't really care who created the document as long as everyone can reach the vulnerable populations that we need to serve. So, a few more residents. The form has bubbles and the font is really little, so I think those of you who went through the internal dispensing exercise, it's the same form. A little challenging, didn't work quite so well with this population, so we need to address that, as well as some language barriers related to that form. Great fun, lots of questions, a follow-up sheet. We realized that a follow-up sheet with just general questions, not related to the medication, but about the incident, was super valuable. I got stopped in the restroom after this by some lady that was like, asking about anthrax and making sure she was okay. It's just an exercise, you're okay, ma'am. So this is one way that we target a vulnerable population. We actually have another agreement with the Developmental Disabilities Resource Center just across the street the other way. Not for dispensing medications, but for dispensing the information on where to find the medications. Because that is the population that is challenging linguistically, mentally, behaviorally, and trust. And so having the members of their staff who normally work with that population give them the information about the incident will increase the uptake of antibiotics within that population. So that's another way that we go about targeting it. Within JEFCO, I think I heard some of you, Nurse Family Partnership, the WIC clinic, those are vulnerable populations as well. And those are populations where we will need to work through what information is needed by those clientele, and how do we get it to them? How do we get it to a population that doesn't necessarily access the resources all the time that they need to access? We are probably the best conduit to them and that particular population, so we really want to work through good mechanisms to reach them. Talking to Kylie in WIC, we talked about using WIC staff to run our phone bank for us, because that allows them to stay here and continue to work and continue to serve that clientele, but also assist with the response. And they have the languages that we need in order to address populations. So that's something that we're working on with that particular population. So that is really student-driven with some guidance from us who've been in the program for a while. So if you ever come across Sarah, please talk to her about this. This is really, really great, and I don't think she understands the impact of what she's done for public health at the local level. And now, #lunch. So, are there any questions?